Welcome back to the deep dive. Today we are shifting gears. We're stepping out of the theoretical abstract and right into the fire of the examination hall.
I know this feeling.
I want you to picture this. It's a humid morning in Ahmedabad. You're standing outside the Viva Hall at Gujarat University. Your white coat is pristine, but your palms are sweating. You're about to walk in for your MD Anesthesiology final practical exam.
That is a feeling every single consultant remembers. The dry mouth, the racing heart, and that, absolute certainty that the external examiner knows exactly what you don't know.
Exactly. And that examiner isn't there to ask you about the basics of cannulation. They're waiting to ask you about the nightmares, the moments in the OT where the monitors go red and the surgeon stops talking. We're tackling the holy trinity of crisis topics today. Venous air embolism, deliberate hypotension, and the anesthetic management of a patient with paraplegia.
These are high-stakes topics, and not just for the exam, where they are, let's be honest, favorite 20-mark-long questions, but for your career. I mean, if you mishandle these in the exam, you fail. If you mishandle them in the OT, people die. It's that simple.
So the mission today is simple. I'm playing the role of the final year resident. I've read Miller, I've highlighted Morgan, and I've, memorized the tables in the ICU book. You are my senior faculty mentor.
Okay.
You're going to grill me, guide me, and help me synthesize these stacks of PDFs into the kind of polished, distinction-level answers that get a nod of approval from the grumpiest examiner.
I like it. Let's assume I'm that external examiner, the one who thinks the latest edition of Miller is a bit too modern and prefers the classic physiology. So let's begin.
All right, Part A, venous air embolism, or VAE. This is a classic potential long question. If I'm opening my answer, I need a definition that sounds like I didn't just make it up.
Correct. Don't drift into it. Hit me with a definition. What is VAE?
Okay, so VAE is the entrainment of air or, any exogenously introduced gas from the operative field into the venous circulation.
And then where does it go?
It travels to the right heart and then into the pulmonary circulation.
Good. And why should the examiner care? What's the headline danger here?
Well, it's a life-threatening emergency. The real issue is that it causes acute right ventricular outflow obstruction.
Exactly.
It's not just bubbles in the blood. It's acute cor pulmonale and, cardiovascular collapse.
Precisely. Now, set the scene for me. In the exam, they will absolutely ask you which surgeries are the main culprits. Everyone knows the sitting position craniotomy.
But that's not enough for a complete answer.
Not for top marks, no.
Right. So posterior fossa surgery in the sitting position is the classic teaching case. That's because the dural sinuses are non-collapsible. They're held open by bone.
Good. What else? Think about modern surgery.
Okay, so looking at current practice, we have to mention laparoscopy. That's a gas embolism with CO2, but the mechanics, the basic idea, it's similar.
Very important distinction, and a common source of trouble. Keep going.
Then there's central venous catheter insertion or removal, especially in patients who are hypovolemic, and some lesser-known ones, maybe, like posterior spinal fusion, or even a cesarean section if the uterus is exteriorized and the broad ligament veins are open and above the level of the heart.
Excellent. You've read beyond the first paragraph. You mentioned the mechanics. Let's dive into that. Section 2, Pathophysiology. This is very high yield.
Okay.
The examiner asks you, Doctor, physics dictates that fluids flow down pressure gradients. How on earth does air get into a pressurized vein?
This is where I'd bring in the concept from the ICU book. It's basically a two-step prerequisite.
Okay, what are they?
First, you need a direct communication between a source of air and the vein, an open vessel. That's obvious.
And second?
Second, and this is the absolute key, the pressure inside that vein has to be subatmospheric. It has to be negative compared to the air outside.
And how much negative pressure are we talking about? Does it need a massive gas?
No, and this is the scary part. It's shockingly little. The data point that always sticks with me is that a gradient of only 5 centimeters of water.
Which is tiny.
Tiny. It's basically a slightly deep inspiration. That gradient across a 14-gauge needle can entrain 100 milliliters of air per second.
100 mils per second. Let that sink in. That is a lethal dose in literally 2 or 3 heartbeats.
It's terrifying.
Now, walk me through the airlock. The air is in. What is happening inside the heart?
So the air gets into the right atrium, and then it's pumped into the right ventricle.
Yeah.
But air is lighter than blood, so it floats.
Right.
It accumulates at the top of the right ventricle, specifically obstructing the pulmonary outflow tract. The RV is trying to pump, but it's just compressing a gas bubble.
And gas is compressible. Blood isn't.
Exactly. So forward flow,
Right.
it effectively stops. You get an airlock.
And what are the downstream effects of that lock?
The pulmonary vascular resistance, the PVR, it skyrockets. This leads directly to acute right heart failure.
And what does that do to the left side of the heart?
Because of ventricular interdependence, the interventricular septum bulges into the left ventricle, so LV filling gets impaired and cardiac output just crashes.
You also mentioned gas exchange earlier. What happens there?
Right. The air that does manage to get into the pulmonary arterioles, it blocks perfusion. So you end up with alveoli that are ventilated.
Air's going in and out.
But they're not being perfused.
Yeah.
There's no blood flow. And that creates a massive increase in physiological dead space.
Perfect. There's one more concept you absolutely must mention to get full marks. It's rare, but it's a killer.
Paradoxical air embolism.
Tell me about it.
This is the stroke scenario, basically. Normally, the lungs can filter out small bubbles.
Yeah.
But if the patient has a patent-foramen ovale, a PFO.
Which is pretty common, right?
Yeah, about 25% of the general population has one.
Yeah.
And things get really dangerous then. When the RV fails, the right atrial pressure shoots up.
And if it exceeds the left atrial pressure?
That PFO can open, air shunts right to left, it gets into the systemic circulation.
It can go anywhere.
Up the carotids to the brain causing a stroke, or down the coronaries to cause an MI, a disaster.
Perfect. That explanation covers the why and the how. Let's move to section 3, risk factors. We touched on the sitting position. Miller is very clear this is the highest risk.
Yeah, because of the gravitational gradient. The head is so far above the heart, creating this really significant negative venous pressure.
But it's not the only risky position.
No, we also need to be vigilant in the prone position. I think Morgan mentions this for spine surgery. If the operative site is elevated higher than the heart, the risk exists.
Good. Now, what about the central line? I feel like this is a classic ward call trap that can happen outside the OT.
Absolutely. It can happen during insertion if the patient takes a deep breath and the hub is open to air.
But what about removal? People get complacent.
Yes, removal is a huge risk. If the patient is sitting up or inspires deeply as the line comes out, air can track right down the subcutaneous tract into the vein.
Correct. Always remove CVCs with the patient in Trendelenburg or at least supine. Now, let's go to section 4. Clinical features. This is the core of the exam case scenario. You are the anesthetist. The patient is sitting up. What happens? What do you see first?
If I'm watching my monitors like I should be, the classic and probably most sensitive practical sign is the sudden fall in end-tidal CO2, the ET-CO2.
Why does it drop? Is it because the patient stopped breathing?
No, it's not apnea. It's that dead space we just talked about.
Yeah.
Blood isn't reaching the lungs to offload CO2.
So the gas being exhaled has no CO2 in it.
Exactly. The air coming out of the trachea has very little CO2. You see a sudden, almost exponential drop in the capnography trace. I mean, it can go from 35 straight down to 10 or 12 in seconds.
And at the same time, what's happening to the blood pressure and heart rate?
Hemodynamically, you get hypotension and a reflex tachycardia. But the key point is that the ET-CO2 drop usually precedes the blood pressure crash. It's your earliest warning.
What about hypoxia, the SpO2 probe?
Hypoxia happens, but it's a late sign. By the time the SpO2 starts to drop, a massive VQ mismatch has already occurred.
So if you wait for desaturation,
You've likely missed the window to prevent a cardiac arrest. You're way behind.
now the examiner will definitely ask you about the mill-wheel murmur.
Ah, the classic medical student answer. It's described as this churning, splashing sound heard over the precordium, like a washing machine.
But practically.
Practically, if you can hear that with a stethoscope on the chest, there's already a massive volume of air in the heart. The ICU book calls it a pre-terminal sign.
Exactly. It's great for textbooks, bad for patients. Let's talk about diagnosing this before the murmur starts. Section 5, diagnosis and monitoring. If you had an unlimited budget, what is the absolute gold standard?
Transesophageal echocardiography. T.E. Miller is crystal clear on this. It can detect microbubbles as small as 0.02 milliliters per kilogram. It literally visualizes the air in the RA and RV immediately.
But in many centers, we don't use T for every single case, so what's the next most sensitive tool?
The precordial Doppler. This is the most sensitive, non-invasive monitor.
Well, where do you put it?
You place the probe over the right sternal border, usually between the 3rd and 6th intercostal space. It picks up the turbulent sound of bubbles, that wash machine sound, long before your ear ever could.
Rank them for me. Give me the sensitivity hierarchy for the exam.
Okay, number 1 is TE, the gold standard.
Yeah.
Number 2, precordial Doppler. Then number 3, a pulmonary artery catheter, which would show a sudden rise in PAPs.
And then?
Number 4, capnography, the ET-CO2. Then 5 is hemodynamic changes, so BP and heart rate. And dead last.
Is your stethoscope?
My stethoscope.
And remember, while ETCO2 is number 4 in sensitivity to tiny bubbles, it is the number 1 practical monitor because it is universal.
Right, it's on every machine.
Every machine. A sudden drop in ETCO2 in a high-risk patient is VAE until you can prove it's something else.
Got it. Now, the crisis is happening, section 6.
Yeah?
Management. The examiner says, "Doctor, the ETCO2 just dropped to 15. The surgeon is still operating. What do you do?"
This is where you need to be commanding. No hesitation. Give me the checklist step by step.
Okay. Step 1. Inform the surgeon. Loudly and clearly. Stop operating. Flood the field. They need to pour saline into the wound to submerge any open veins and wax the bone edges immediately.
Good. Step 2.
Step 2. Stop nitrous oxide if it's being used.
Why? What's the physics?
Physics again. N2O is about 34 times more soluble in blood than nitrogen is. So you'll rush into that air bubble way faster than nitrogen can leave it.
Making the embolus
bigger. You are actively expanding the embolus, so you turn it off and switch to 100% oxygen.
Good. Step 3, it's a maneuver.
The Durant maneuver. We have to reposition the patient, put them in the left lateral decubitus position with the head down, so Trendelenburg.
Explain the physics of why that specific position helps.
It uses buoyancy, right?
Yeah.
We want to trap the air in the apex of the right ventricle, which is now the highest point.
And what does that achieve?
By putting the left side down, the RV outflow tract is now below the air bubble. This allows blood to flow underneath the airlock and into the pulmonary artery, hopefully restoring some cardiac output.
Excellent. Step 4, you have a line in the patient.
Aspiration. We try to suck the air out. This requires a central venous catheter, ideally a multi-orifice catheter placed right at the SVC-RA junction.
Is a regular CVC okay?
It's better than nothing, but Miller specifically says single orifice catheters are much less efficient at retrieving air. You want those multiple holes.
And finally, the patient is still hypotensive.
Cardiovascular support. You give fluids to fill the veins to increase the CVP, and you use vasopressors like noradrenaline or ephedrine to fight the hypotension.
And if the worst happens?
If they arrest, you start CPR. And Morgan actually notes that chest compressions might help by breaking large air bubbles into smaller ones that are easier to pass through the circulation.
Excellent. A final brief point. Section 7, prevention. How do we stop this from happening in the first place?
It's all about vigilance. Meticulous surgical hemostasis is number 1. Then, from our side, keeping the patient well hydrated to maintain a high CVP. Turgid veins don't suck in air as easily as collapsed ones.
And one drug choice.
Arguably, just avoiding nitrous oxide in high-risk cases like sitting craniotomies altogether.
Good. That wraps up VAE. You've demonstrated the mechanism, detection, and action. Let's pivot. Part B. We are going from accidental hypotension to intentional hypotension.
Deliberate or controlled hypotension. This feels like the art of anesthesia section.
It is. Define it for me.
Deliberate hypotension is the elective lowering of arterial blood pressure. The goal is to reduce surgical blood loss and improve the visibility of the surgical field for the surgeon.
Good. And what's the rationale? Where do we use this?
It's big in neurosurgery for things like aneurysms or vascular tumors, spine surgery to reduce that awful venous oozing from the epidural plexus, also in orthopedics like total hip replacement, and for middle-ear microsurgery where even a single drop of blood can completely obscure the surgeon's view.
Okay, section 9, physiological basis. This is where you earn your distinction marks. How does lowering the BP actually help? And more importantly, what are the limits?
Well, the basic physics is that flow is proportional to pressure. So less pressure, less bleeding. The equation is MAP equals cardiac output times SVR.
Right.
So we could lower the BP by either dropping the cardiac output, maybe with beta blockers, or dropping the SVR with vasodilators. But the really critical concept here is autoregulation.
Explain the autoregulation curve and how it shifts. This is the key exam concept.
Okay. So normally the brain and the kidneys can maintain a constant blood flow across a really wide range of mean arterial pressures. The classic teaching is a plateau between a MAP of 50 to 150 milliman AGO.
But that's for a healthy person.
Exactly. In patients with chronic hypertension, that whole curve shifts to the right. Their lower limit of safety might be a MAP of 70 or 80, not 50.
So what happens if you take that patient to an MAP of 55?
That case suffers cerebral ischemia, a stroke. Even though a healthy 20-year-old would be perfectly fine at that pressure, you have to know your patient's baseline.
Precisely. And some sources also point out that autoregulation is lost in diseased tissue, like around a tumor or an area of trauma.
All right, so the flow becomes pressure passive there.
Exactly. So your deliberate hypotension might actually be starving the very tissue the surgeon is trying to save.
That's a huge caution. Okay, so let's look at the toolkit, section 10. Methods. How do we achieve this hypotension safely?
Let's start with the drugs. What's in your pharmacological arsenal?
Well, the easiest are the volatile anesthetics isoflurane, sevoflurane. They're potent vasodilators in a dose-dependent way.
What's the downside?
High concentrations can interfere with evoked potential monitoring, which is a big deal in spine surgery.
True. What about the classic IV vasodilator?
Sodium nitroprusside, or SNP, is the textbook classic. It's a nitric oxide donor, works on arteries and veins. It has a super fast onset and offset, which is great, but it has baggage.
What kind of baggage?
Cyanide toxicity with high doses or prolonged infusions. And you can get this nasty rebound hypertension. When you stop it, the BP can overshoot dramatically. Plus, it causes cerebral vasodilation, which can raise ICP.
So it's fallen out of favor a bit.
Yeah, compared to newer drugs.
Such as
Remifentanil. This is really the modern workhorse for this. It's an ultra-short-acting opioid metabolized by nonspecific plasma esterases.
Why is it so much better than SMP?
It provides fantastic hemodynamic stability without all that toxicity. It lowers the BP by decreasing sympathetic tone and heart rate. It's incredibly titratable. You turn off the infusion, and its effect is gone in minutes.
Good. And what if you have a patient who's getting tachycardic?
Then you reach for a beta blocker. Esmolol is perfect. It's cardioselective beta-1 and also metabolizes really rapidly by red blood cell esterases. It's great for controlling the heart rate, especially if you're using a drug that causes reflex tachycardia.
Okay. Section 11, targets. How low do we go? Is there a magic number?
There's no single magic number. The general safety rule is to keep the MAP within 20–30% of the patient's baseline. Or, for a healthy ASA-SAM patient, an absolute MAP of maybe 50 to 60 mmHg.
There is a specific ratio I want you to mention to show you're thinking about the heart.
The Buffington ratio.
Tell me about it.
Yes, it's the MAP divided by the heart rate. We want to keep this ratio greater than 1. So if your MAP is 60, your heart rate really shouldn't be much higher than 60.
And why is that so critical?
It's all about myocardial perfusion. The heart perfuses itself during diastole. If the heart rate is fast, diastole is short. If the BP is also low, that's a low driving pressure. The heart can starve. Keeping the ratio above 1 helps ensure the heart gets enough oxygen.
And what's the one monitor you absolutely must have?
An arterial line. It's mandatory, beat-to-beat monitoring. You absolutely cannot do deliberate hypotension with a non-invasive cuff cycling every 5 minutes.
What else are you watching?
Urine output, to make sure the kidneys are still getting perfused.
Okay. Section 12. Advantages versus disadvantages. This is a perfect table to draw in the theory paper. Give me the highlights.
Okay, so for advantages, you get reduced blood loss, which means less need for transfusion. The surgeon gets a dry surgical field, which is critical for precision, and often it reduces operative time.
Now the dark side, disadvantages.
The biggest one is the risk of organ ischemia. Brain, so stroke, heart, an MI, kidneys, and acute kidney injury. You can also get a delayed awakening if drug clearance is slow. And then there's reactionary hemorrhage.
Explain that.
That's when you bring the blood pressure back up to normal at the end, and vessels that had clotted off at the lower pressure start to bleed again.
And one rare but terrifying complication, particularly in long, prone spine cases.
Ischemic optic neuropathy. Blindness. The optic nerve head loses its perfusion. It's a nightmare scenario.
Section 13. Contraindications. Who do we absolutely never do this to?
You'd never do this to patients with severe ischemic heart disease or cerebrovascular disease. Their plumbing is already compromised.
Good. Who else?
Patients with severe anemia, because oxygen delivery is a product of cardiac output and hemoglobin. If your HP is already low, you cannot afford to lower the cardiac output or the pressure. And of course, anyone with significant renal or hepatic dysfunction.
Perfect. You've navigated the controlled shock. Now let's move to Part C. The most complex physiological challenge. Anesthesia for the patient with paraplegia.
This topic always scares me. It just feels like a minefield, absolute do's and don'ts.
It is, but it's manageable if you understand the underlying physiology. Let's start with section 14 and 15, the introduction and the pathophysiology. We aren't just talking about someone in a wheelchair. We are talking about a completely rewired physiology.
Right. So paraplegia usually results from a spinal cord injury. The two key factors for us are the level of the injury and the time since the injury occurred.
Good.
Pathophysiologically, you obviously lose motor and sensory function below the lesion, but the absolute killer change for anesthesia is the upregulation of acetylcholine receptors.
Elaborate on that. This is the critical succinylcholine point.
So normally, acetylcholine receptors are confined to the neuromuscular junction. But after denervation, which usually starts about 24 hours after the injury, these fetal-type extrajunctional receptors start to spread across the entire muscle membrane.
And they stick around.
They do. This proliferation peaks at a few weeks, but persists. Well, some books say potentially for the rest of their life.
And why does that matter to us?
Because if you give succinylcholine, which is depolarizing muscle relaxant, all of those extra receptors depolarize at once, not just the ones at the junction.
Causing what?
A massive catastrophic efflux of potassium from the muscle cells into the bloodstream.
How massive are we talking?
Massive enough to cause a hyperkalemic cardiac arrest within minutes, an arrest that is almost impossible to resuscitate from. So the golden rule is no exmethonium in paraplegic patients, ever.
Unless it's within the first 24 hours of injury, but for exam purposes.
Just say no. Use rocuronium.
Correct. Now, section 16. Autonomic dysreflexia, or AD. This is the other exam favorite on this topic. Define it for me.
AD is a massive, uninhibited sympathetic discharge that happens in response to a stimulus below the level of the spinal cord injury, and it typically happens in lesions above T6.
Why is T6 the magic number?
That's the level of the sympathetic outflow to the splenic vascular bed, the big blood reservoir in the gut. The mechanism is fascinating.
Walk me through it.
So first, a stimulus occurs below the lesion. Usually it's a distended bladder from a blocked catheter. That's the #1 cause. Or maybe the surgeon cutting the skin.
Okay, so the signal goes up the cord.
Right, the afferent signal travels up the spinal cord, but it hits the blockage at the lesion, can't get to the brain. Instead, it triggers a massive sympathetic reflex right there in the isolated spinal cord.
And what does that reflex do?
It causes severe, widespread vasoconstriction below the level of the lesion. The blood pressure skyrockets. I mean, it can hit 250 systolic.
But what's the brain doing?
The brain senses this dangerous hypertension through the baroreceptors in the neck. It tries to fix it. It sends inhibitory signals down the cord, but they can't get past the lesion, so the vasoconstriction just keeps going.
So what's the only tool the brain has left?
The vagus nerve. It increases vagal tone to the heart to try and lower the cardiac output.
So the clinical hallmark is the classic combination.
It's severe hypertension with a reflex bradycardia. You also see this classic split sign, flushing and sweating above the lesion from vasodilation and pale, cool skin below the lesion from the intense vasoconstriction.
Excellent. This brings us to section 17, preoperative assessment. You're seeing this patient in the clinic before surgery. What are you looking for specifically?
Okay, so apart from the usual airway and cardiac check, I'm focused on a few things. One, the level of injury. Is it above T6? If yes, my alarm bells for AD are ringing.
Good. What else?
2, respiratory status. If it's a high lesion like a cervical or high thoracic injury, their intercostal muscles are paralyzed. They're purely diaphragm breathers. Their cough is weak. I need to know if they can clear secretions.
Very important.
3, a skin check. I need to physically look for pressure sores or decubitus ulcers. These can be sources of chronic infection and even sepsis. Then 4, potassium on a baseline electrolyte level. And 5, their spasticity meds.
Like baclofen.
Exactly.
Yeah.
You can't just stop it abruptly, or they can get withdrawal seizures.
Okay. Section 18, anesthetic management. The surgeon wants to do a cystoscopy. What technique do you choose?
This is a classic Viva trap. The surgeon says he has no sensation below his waist. Why do we even need anesthesia?
And your answer is?
We need it to prevent autonomic dysreflexia. We have to block the afferent limb of that dangerous reflex. The patient doesn't feel the pain, but their spinal cord sure does.
So what's your technique of choice?
For that reason, spinal or epidural anesthesia is often the best choice. It provides a dense block that stops the stimulus from ever reaching the spinal cord in the first place.
But what if you can't do a spinal?
True. Their anatomy might be a mess, kyphoscoliosis, previous fixation rods. It might be impossible. In that case, we use general anesthesia, but it has to be deep GA.
Why deep?
Because light anesthesia won't be enough to suppress that AD reflex. We effectively have to treat them like they can feel the pain, even though they can't.
Very good. Section 19, intraoperative and postoperative considerations.
Okay, positioning is huge. They can't feel pain or pressure. We have to pad every single pressure point meticulously. A 4-hour surgery could cause a necrotic ulcer that takes 6 months to heal.
What about their temperature?
They are poikilothermic below the lesion. They can't vasoconstrict or shiver properly. They just assume the temperature of the room. So we need forced air warmers and warm fluids very aggressively.
And one other major risk.
DVT. Morgan highlights the extremely high risk of deep vein thrombosis because of the venous stasis. So we need compression devices on their legs and probably chemical prophylaxis if it's not contraindicated by the surgery.
Okay. Section 20, the Viva traps. I'm the examiner again.
Go for it.
Doctor, your paraplegic patient is under GA for a bladder stone removal. Suddenly the BP is 220/110 and the heart rate is 45. What is happening and what do you do?
That is classic intraoperative autonomic dysreflexia. My actions are immediate. 1, I tell the surgeon to estabopi immediately. Remove the stimulus.
Good. Then what?
2, I deepen the anesthesia. A bolus of propofol or turn up the volatile agent. 3, I check the urinary catheter. Is it kinked or blocked? That's the most common cause.
And you need to lower the blood pressure fast. What do you give?
A rapid-acting vasodilator. GTN, SNP, or labetalol would all be good choices.
Is there anything you would not give?
You would not give a pure beta blocker on its own because you'd leave the intense alpha vasoconstriction unopposed and could actually make the hypertension worse. Plus, the heart is already bradycardic.
A perfect safe answer. Finally, section 21, diagrams and exam presentation. You have 5 minutes left in the theory exam. What quick diagrams do you draw to get extra marks?
Okay, for VAE, I'm drawing the flow chart. Negative pressure leads to air entry, leads to an RV airlock, which causes increased dead space and decreased cardiac output. And I draw a little capnography trace showing that cliff drop to near zero.
Good. For dysreflexia?
The schematic of the reflex loop. Stimulus below the lesion goes to the cord, causes sympathetic outflow, leading to hypertension. Baroreceptors sense this, fire the vagus nerve, causing bradycardia.
And for deliberate hypotension?
The autoregulation curve graph. I draw the normal plateau and then show the hypertensive curve shifted over to the right.
Excellent. Section 22. Summary and conclusion. Bring it all home. Give me the high-yield bullet points for the drive home before the exam.
All right, here's the synthesis. For VAE, it's a pressure gradient problem, and 5 centimeters of water is all it takes.
And what do you watch?
Watch the ETAO2 like a hawk. It's the first and most practical sign, if it drops. Flood the field, give 100% O2, turn off the nitrous, position the patient left lateral head down, and try to aspirate the air. Don't wait to hear the mill wheel murmur. It's too late. Hypotension, or deliberate hypotension.
Yeah.
It's a balance between surgical view and organ perfusion. Keep the MAP above 50 to 60, or within 30% of the patient's baseline. Watch the Buffington ratio, MAP over heart rate, keep it above 1.
Your drugs of choice.
Remifentanil, or Esmolol for fine control. And remember, it's contraindicated in patients with bad hearts, bad brains, or bad blood counts.
And finally, paraplegia.
For paraplegia, number 1, with flashing lights, no succinylcholine. It causes hyperkalemic arrest. Number 2, if the lesion is above T6, you must anticipate autonomic dysreflexia.
The triad of which is?
Hypertension, bradycardia, and that weird sweating above and paleness below the lesion. Regional anesthesia is a great way to block it. And finally, pad all the pressure points and actively warm the patient.
A final thought for the road. Something to chew on.
As we move toward more robotic surgery and minimally invasive techniques, the incidence of that classic open vein air embolism might be decreasing, but the risk of CO2 gas embolism in laparoscopy and robotic surgery is probably higher than ever.
An interesting point. And for paraplegia?
And regarding paraplegia, as trauma care improves, we're seeing more and more patients living longer with high spinal injuries. These aren't rare cases anymore. They're coming to your OT for gallbladders and kidney stones, and you have to be ready for their unique physiology.
You are ready. That was a distinction-level performance. Go crush that exam.
Thanks, Prof. And to our listeners, good luck. Deep dive out.